Hello everyone and welcome back to IB Psych Revision. Today we are starting a three-part series which is .5.7 Examine Approaches to Treatment and is looking at biomedical individual and group treatment, but you should be aware that in the exam they could break it up into just one of those types of treatment, so it's important that you look at each of them in depth. So to start with, what we really want to be looking at is that treatment is linked to the suspected etiology of the disorder. And looking at our command term examine, which is really looking at the assumptions and interrelationships of the issue, you can see that the assumption here is that if we are using a biomedical treatment, then it is likely that there's a suspected biological cause. So I have split this up into the three main types of biomedical treatments, and those are psychosurgery, electroconvulsive therapy, and drug treatment. Just before you start, you should be aware that biomedical treatments have the highest success rate with serious psychoses, which means it just means if there is a very severe problem. Okay, let's start with psychosurgery. So I've split up into the explanation and an evaluation of the strengths and limitations. Psychosurgery has traditionally been the prefrontal lobotomy, which severs connections between the prefrontal cortex, which is just behind your forehead, and deeper structures within your brain. It was developed and popularized by a man named Moniz, and he applied it to a wide range of mood, anxiety, and personality disorders, but particularly for schizophrenia. It was pretty much designed for schizophrenia, but as you can see, he was quite indiscriminate in using it. Nowadays, it is used very much as a last resort to treat depression and OCD, and we do not use it anymore to treat schizophrenia, and it takes a different form. It's called a capsulotomy, and it is much more specific, wherein an electrode is inserted into the brain and it damages some tissue. So what are the strengths of psychosurgery? To be quite honest, there aren't many. It was initially hailed as a wonder cure and something that was needed to bring the psychiatric profession respectability, which isn't really a strength at all, and that was noticed by Wallenstein. It could be effective in treating depression. Limitations are much more extensive, and they are mainly the reason for which it is mostly abandoned today. So it's ineffective at combating precise symptoms. There's a possibility of seizures. There's a 1 to 4% chance of death. It causes profound changes in personality, motivation, and cognitive abilities, which was noted by Beharel. And this isn't really surprising considering most of the time they were kind of just putting a stick into your brain and kind of waving it around, which, yeah. Anyway, so some people didn't even see it as a means of treating mental illness, more like a means of social control. And this is evident because of the lack of scientific basis, the inconsistent outcomes of this, and also the irreversibility, which is really an important point to note. Once you have it done, you can't really do anything about it, even if it has caused you a lot of pain and struggle. So eventually we moved on from psychosurgery for the most part, and today we have electroconvulsive therapy. So it's a unilateral or bilateral shock, so that means either to one hemisphere or both hemispheres of the brain, approx 100 volts so as to induce a seizure. It has been linked to memory loss, but it seems to produce relief from symptoms. No one knows how it works, but it's usually given 6 times over a period of 3 to 4 weeks, usually applied to the non-dominant hemisphere, obviously if it's unilateral, otherwise both. Muscle relaxants and anesthetics are given to avoid harm, because obviously if you're having a seizure, you're flailing about quite a bit and there's a possibility that you would harm yourself. It is only used in severe cases of depression, and that's especially when the suicide risk is imminent, because it works very quickly, unlike drug therapy, which can take a number of weeks, and the same for cognitive or behavioral therapy. So originally they thought, like with psychosurgery, that it should be applied to schizophrenics who were thought not to experience epilepsy. This was wrong on 2 counts. Schizophrenics can experience epilepsy, and it's no longer used for schizophrenia, as I said, mostly for severe cases of depression. It actually is the most effective treatment in severe depression, and it has a symptom relief in 60 to 80% of cases, which is a lot. It's considered low risk, and it's effective in providing immediate therapy. As I said, if the suicide risk is imminent, then you probably want to go for this one. You must include, though, that it is not known how it works, and that's by Saracen. There is a suspected overuse of it and abuse of it. It does carry a small mortality risk, and there are ethical consent issues, such as if someone has a suicide risk, is it ethical to force them to go through it for their own sake, or is it not? So that must be overcome in some way. The third one is drug therapy, and drug therapy is by far the most used one compared to the other 2. There are 4 kinds of drugs that are used in psychological therapy, and those are neuroleptics, antipsychotics, antidepressants, and anti-anxiety tranquilizers. And they all work in different ways, but essentially they're looking at neurotransmitters and neurotransmitters. So what's good about drug therapy? First, when they were introduced, there was a massively reduced need for institutionalization, which is really good because it really brought the pressure off of that system. They're easier to administer, so they don't require going into hospital or extensive surgery or anything like that. And some of them are very effective, such as lithium is effective in 80% of bipolar patients. There are limitations, of course. So, for example, on neuroleptics, there's no improvement for up to 25% of people. The delayed effects, as we've already talked about. No drug is 100% effective. It may be considered reductionist in that it doesn't take into account the person existing within their community, social factors, cultural factors, and cognitive factors. It cannot treat social incapacity, which is much better treated with cognitive and behavioral therapy. And that's one of the reasons why there is a lesser risk of relapse if you have cognitive behavioral therapy. Of course, every drug has side effects, and these can be quite horrible. But the newer ones, that's less of a problem. You also need to find the correct dose. You require medical supervision, and a lot of people think there is a risk of overprescription of these drugs. However, Baxter does note that if a disorder has a biological cause, even cognitive and behavioral therapies can produce biological changes. And he supports that by the fact that PET scans are the same in OCD patients treated solely with Prozac, which is a SSRI antidepressant, or cognitive behavioral therapy, CBT. There's also the possibility of relapse. So that's up to 70% in schizophrenia, which is a lot. Possibility of dropout, so that's also a lot. McGrath notes half to 2/3 of patients on antidepressants stop taking them before the course of treatment is finished. And Kirsch is a really good study that kind of sums up the limitations, and he shows that a meta-analysis of 19 double-blind studies show that 75% of a drug's effect is due to placebo and non-chemical effects. So that's quite a lot. And if we're wanting to test the relative efficacy, we really should be looking at longitudinal, placebo, and double-blind assessments. So that's that for the examine approaches to biomedical treatments. Thank you for watching. See you next time.